Good afternoon, and welcome to everyone who's joining us today, both locally and here in the United States, and also to our global visitors who have joined us. We'll be speaking today about assessing and evaluating competence through the curriculum. And in preparing for this, my name is Darren LaCroix, and I'm a consultant for Laerdal Medical, and I came out of retirement actually for this project. I was asked to come in and do some work with 3 schools of nursing, and we were working with utilizing data and incorporating data into schools of nursing. I thought about it and compared that use of data to Lego building blocks. And all of us that are here and joining on the webinar today collect data regularly. We collect data in many forms. We collect subjective data, we collect objective data, formative data, summative data, organizational data, curricular data. And think of it as those Legos where it comes from all different sources and it ends up being in a big pile. And we generally take that pile and we organize that pile into nice little silos, right? We have the organizational data together, curricular data ends up together. We put them all into their own little box. And frequently we don't do anything with that data. And what we do know is that that data tells a story. That data has something to say. It has something to say to your institution. It has something to say to your program. It has something to say to your faculty and specialists that work in your programs. It has something to say to your students. And so what we're going to do today is we have with us 3 representatives from exceptional schools of nursing. When I was going to these schools and meeting these people, I went into schools that were progressive, that were willing to try something, that were concerned about the student and really were focused on meeting institutional goals. And that's pretty special. We don't see that in everywhere. The representatives represent the University of Texas at Arlington. I have a lot of experience with the University of Texas at Arlington, probably worked over there with them in various projects throughout my career for 16, 17 years probably. We have Penn State University, again, another leader in simulation, employing deliberate practices, employing deliberate strategies of implementation with those. And we have a representative from the University of Massachusetts, Boston. And so I'm going to let them introduce themselves as we go. I certainly will give an introduction to our first guest, which is Jenny Roy. And Jenny is the Assistant Dean for Simulation and Technology. But what I do know about you also, Jenny, having known you for a little bit, is that they've given you also another title and another duty, and that's construction of a new building.
Yep. It's a really exciting time at UTA. We are moving into our new facility.
There it is there.
In about 30 days. January 2nd is move in. January 17th is first day of simulation. So we will be up and operational. We will be up and operational by then.
Good. And you've been in operational school for quite some time. You have an outstanding graduating percentage rate. NCLEX rates, I know, are some top in the country, and you recently received an award. So what about this move to this building really has changed you're really looking at evaluation now, and we've spoken about this. What is it that gave you this opportunity?
Well, when we move into the new building, operations will change. It's new configuration. Simulations are going to be done a little differently than they were in the old facility. So it really gave us a chance to kind of dissect our program and look deeper to see where we could make sure that our objectives are all aligned. It comes at kind of a perfect time because we are, again, looking at simulation objectives to align to the course objectives, to align to the program objectives, but also we are working with our curriculum, redesign curriculum evaluation to make sure that those standards align with the CCNE new essentials as well.
And it sounds as if probably to the listener, oh, they're just taking this on and getting this started. But I wanted to kind of remind you, so I pulled up an old picture of one of our first meetings together. This is from back in 2020, somewhere, 2000, somewhere.
Somewhere there, yeah.
Might have been pandemic days. We were probably wearing masks. But we were already strategizing, as I recall, and some of the things that we talked about then that you're addressing now, inter-rater reliability, utilizing an evaluation tool. You can see that we had plans to introduce this. We were working in a capstone, looking at your operations and building. So it's been something that's been coming for some time.
One of the things that we would love to do is to like your Legos, we have data in every platform. So pulling that together with clinical evaluation data, simulation evaluation data, and getting it all in one platform where we can measure it longitudinally across the program. It would give us a good sense of how our students are progressing, but it could also be very important to students to see how they're progressing.
Mm-hmm.
Had a conversation with one of our lead teachers, and he likened it to the students want to know what color shoes to wear the first day of clinical,
Mm-hmm.
but by the end of clinical, they are putting in Foley catheters or giving medication. So it would be great for them to see their progression across the course, across the program.
Yeah, I think so. And you have mentioned, and we're definitely going to be speaking about that. And also you mentioned about the data to support your clinical activity. So we'll certainly speak about that. It's great to have you here, Jenny. We've worked together some time. My next guest from Penn State University, Dr. Chris Garrison, is the Associate Teaching Professor at the Ross and Carol Neese College of Nursing, and he also directs their Simulation Center at the main campus. Welcome, Chris. I'm glad to have you here. We've spent lots of time together, and I'd like to hear a little bit about Penn State and what you're doing with the evaluation.
Okay, well, thanks, Darren. So we at the University Park campus of the Ross and Carol Neese College of Nursing, we're a large pre-licensure program. That's the program I primarily work in. Of course, we have grad programs, other programs as well, but we admit about 150 students a year to our traditional pre-licensure program. And in terms of simulation evaluation, for a long time, we were pretty much doing what everybody does. We collected student satisfaction surveys after the simulation experience. But we really started to realize we really needed to go beyond that. We needed to look at what were the actual learning outcomes, what were our learners accomplishing. Here you can see a couple of our students running a simulation with a cirrhosis patient. There's a banana bag hanging there. Mm-hmm. And so we looked at the need to use some validated instruments and collect some actual outcome data of student performance. And then now with the new AACN essentials that require competency-based evaluation, we're going to need to use that data to be able to document how our students are meeting those competency-based benchmarks. Mm-hmm.
So really bringing in more robust data that reflects what's actually going on versus maybe an opinion or a feeling. About
correct. We want something that is objective and valid to make decisions on.
Good. And it's really good to have you here. And again, we will speak a lot more about the initiatives that you do have going on there and some of the findings already that we have from each of you. Before we do that, I'd like to introduce my third guest. This is Rosemary Samia from the University of Massachusetts, Boston. She's the director of the Clinical Center for Education and Research. And glad to have you here. Good afternoon, Rosemary.
Thank you for having me. So our program, like Chris's, is undergraduate. We have an accelerated program for 12 months, and then we have our traditional 4-year bachelor's program. And our longevity with data collection really falls in our clinical referral program. And that is a program that has been about 10 years, maybe a little bit more. It serves as a bridge for our students from the clinical setting back into simulation. And it's not intended to be a punitive experience. It's to help support the students so that they can be successful in meeting those clinical objectives and progressing through the course.
So coming from clinical to maybe coming to simulation to remediate, to get better, and then I guess it's probably cyclical that they go right back out to clinical again where they're evaluated.
They do. They go back to clinical, and there's good conversation between the clinical faculty and the sim education team who are individualizing these scenarios.
So you mentioned that was possibly 8 to 10 years of time that you've been doing this.
Easily.
So you're doing evaluation already. What's different? What's the difference in the evaluation that you have going on there and some of the initiatives that you have going on now?
So the clinical referral is a well-established program, right? It runs like clockwork at this point. So what we noticed was that it's a reaction to students, and we wanted to really change that approach to make it more proactive. What can we do to use the data that we have to intervene before the students require a remediation?
Mm-hmm. Is there a problem in the data that you do have? Is it objective, subjective? What is the nature of the data that?
Well, it should all be objective, right? But we do know that with turnover in faculty, our center relies heavily on graduate students who come through, for a couple of semesters at a time. And so they do bring their subjectivity to the program.
Mm-hmm. I found this picture that someone took of us, which there's always, when I come to Rosemary's organization, Jenny's organization too, Chris, there's always a lot of people there. We saw a number of them in a previous picture, faculty. And Rosemary and I were looking at some data here, and we're rather shocked, I recall. I don't want to give anything away, but we'll come back to that data here in a moment.
I'm laughing because when my hair goes into the ponytail like that, it's all business.
Yeah, I recall this moment specifically, and I thought that it was great. Someone captured it. I don't know where the picture came
You
from.
look pretty
but,
serious.
yeah, I think we're working right there. But one last thing that I want to share about the University of Boston, Massachusetts, is I was recently there to do some work with Rosemary and her team, and I got to witness something that I had heard about. And I want to bring it up here in the sense of evaluation, because I mentioned earlier, evaluation is not just about that student. It's not just about a faculty member. It's not just about a curricula, a program. Ultimately, it reflects your institution. And so, Rosemary, if you don't mind, I'd really like you to describe why this picture is what it is. It's a good one.
This is a really, really happy picture of a project. It represents a project that we've had going all semester in collaboration with the Hope House. And the Hope House is an addiction recovery program. It's right in Dorchester, so it's in our campus's neighborhood. They have had 10 clients come every week to our undergraduate health assessment labs. And the clients serve as patients for our students to assess and practice their interviewing. And it's been just a wonderful experience for both our students who are now, they're not interviewing and assessing each other, right? They're interviewing people who can contribute a legitimate patient history as much as they're willing to disclose. And for the gentlemen that come, this is their first positive encounter with a healthcare professional. And when you think about the impact that has on somebody who's going through recovery, we're really addressing the stigma of substance use disorder and mental health. And so I'm very, very pleased. This picture, actually, the students with the Student Nurse Association did a clothing drive for the gentleman. And so this was the actual day that we presented it to them. Yeah, it's great.
It was impactful. That's why I kind of chose the picture, but for a couple of reasons. One, it was impactful that I heard from the man here, Charles, who kind of runs these guys. He told me the impact on these men's lives. He told me the impact that it made, and it was moving. And then again, the impact they're having on your students, you can see there is really good. Again, this is evaluation. This is something that should be evaluated. This is something that should be known by your institution and for your institution, right? This is a very good thing. And I'm sure we could come into examples from both of you, because I know the centers of excellence that you run. So really great, and I love it. So what I'd like to do now is pause for a moment. We're going to actually give you the chance to respond to the audience. We're going to have a few questions here to poll. So Rebecca, if you could bring up that first polling question. And I want you to, before you answer, I want you to really think about this honestly about your program, because no one knows who's answering what, right? So if you're not doing evaluation, you know what? It's okay, right? We're here to help you. That's what we're doing. So I want you to think about these questions carefully when you answer them so that we can see what the data looks like. So our first question, does your organization utilize evaluation tools for formative assessment during high fidelity sims? So when you're running those high fidelity sims with your mannequins and you have a team-based simulation, we're all learning in this. Are you doing an evaluation using a tool on that simulation? So simple yes or no. I'll give you a moment. And Rebecca, whenever you're ready, you can send me the results and we'll take a look at them. So, wow, this is good. This is better. I've done this for a number of years. I've been in simulation over 30 years. So we have 55% of our audience has said that they are doing, utilizing formative evaluation tools, which is wonderful. Congratulations to those of you doing it. 45% aren't, not using them yet. And perhaps that, yet, yes, yet, in a formative setting. So great. Let's see the question number 2. Do 3 quick questions here for you. The second question sounds real similar. As you start to read it, it looks like it was that first question, but the word is different. It is not formative in this question. Does your organization utilize evaluation tools for summative assessment of high fidelity simulations, right? Not skills checkoffs, high fidelity simulations. Do you have a do or die simulation or a summative assessment for that? Again, yes or no for me. How about you guys?
Our simulations are all formative.
Formative.
Ours are as well.
All formative.
We want to maintain that safe learning space where the students really look forward to coming into the Sim Center and learning.
Okay. So we predict high number, low number?
I predict low number.
Low number?
Same.
Let's see those results. Woo. Wow. Again, I have to say this is, again, a change in I've done this a long time and been at a lot of conferences. We have 35% of the population that's on our webinar today are doing summative assessment. 65% say no. I think it's higher than what I expected.
Yeah,
I would agree with that.
Yeah, but it really fits in nicely with, again, we're being challenged to do this, right, as a profession. So now we're going to change gears a little bit, and what I'm really interested in this time is that I know that all of you're each collecting data, right? And I would think that many of the people here on this webinar are collecting data. When have you used data to inform your program of a change that was necessary, and what did you do? And I think I'm going to begin here with Chris, because my recent visit with you, we visited, I believe, on Zoom on this. You and I reviewed some data related to some high fidelity simulations from some senior students, and I'd like to hear that experience from you.
Yeah, so this is using the Creighton Competency Evaluation Instrument, which is a validated tool. And you can see kind of, if you look at the graphic on the right, it evaluates up to 23 separate items. And you can see there's lots of green there, which is good. So there are lots of areas where our students are demonstrating strong levels of competence. For example, practicing precautions, including hand washing, which is great. But if you do dig a little deeper, we do have some areas of concern. So here, these items regarding safe medication administration and performing procedures correctly were not where we ultimately want to be. So if you dig a little deeper in this, the students were identifying the patient, they were doing the rights, but some of the more detailed aspects of administering a particular medication were not always done as should be done. And so we had to then look at this and say, all right, so how can we get our students to the competency level that they need to be for practice? So we started thinking, one of the things that is problematic in a lot of nursing programs is skills are front loaded and oftentimes they're not revisited. And I think that that is a faulty assumption that once you've checked off somebody as being competent in your fundamentals or foundations course, that, oh, they maintain that competence throughout the curriculum. So we really need to look at more of a deliberate practice approach and look at revisiting these skills throughout the curriculum, making sure that we gave them opportunities to kind of redevelop their competency. We use some peer-to-peer methodologies with rubrics so that the students could get feedback as they were practicing. We're collecting more data, and I do expect to see significant improvements in these areas with this year's cohort.
Right. I think it, to me, and I recall our talking about this data, it was pretty stunning to both of us that when we saw the actual numbers there, and not only the numbers, but when you look at the categories, right, is the participant will safely administer medications. We know it's probably the number one safety error of a new nurse going out into practice is, not administering a medication safely. It's pretty scary that this is senior level students. And prior to really being able to extract this type of data, what would you say, was it just if they pass the competency as that first semester student that does 20 competencies, was that it prior to this?
Well, I think it would be revisited in clinical, and also, of course, they're administering medications with their clinical instructor, but the clinical instructor may be kind of guiding them. So the interesting thing about looking at simulation data is that we don't guide them. We expect them to practice independently because there's no risk to patients. Mm-hmm. So that enables us to identify these gaps and then close those gaps prior to graduation, mm-hmm. so that they can be safe and effective practitioners.
And that takes a really objective look, right? This can't just be a cursory, he gave medicines easily, right? This takes a more objective thing. And I think we have some slides a little bit later that we'll talk about with that.
Correct.
Yeah, so good. Rosemary, I know also Chris mentioned that he's put in this deliberate peer-to-peer practice. And I know that you're also using peer-to-peer as a technology, or not a technology, it's a strategy. Mm-hmm. We do have technology that's nice. We can get data, right?
We use that technology to deliver it, right?
Use that technology. Tell me how data has impacted your program.
So we introduced peer-to-peer to our students in their first clinical semesters. So these students are taking health assessment, they're taking their fundamentals of nursing course. And here's some great photos.
Love it.
Yeah, so this was a group that was just in. So every other week they bounce back and forth. We have a 50-50 model where they do half their clinical hours in a hospital and then half in the lab. And wow. So they go every other week, which is a really nice model because they can practice with each other using peer-to-peer, and then they can go to the clinic and apply them with patients. So going back to your question about what we saw in the data, the lab faculty who were open to adopting peer-to-peer and really worked with their students about how to use it together, I tracked their test results for their competencies. And the instructors who had the students using peer-to-peer on a regular basis had much higher first-time pass results than other groups. So we could see that this was a strategy that was helpful, and we ended up incorporating peer-to-peer into some of our remediation processes.
You had told me once that it was taking, this an enormous amount of your faculty time to do remediation. I remember you said that it was almost up to 3 hours that a student would come in, meet with and fine faculty, by the way. Mm-hmm. They're again, back to why they're here. The faculty spend up to 3 hours with the student, one faculty member, right? And sometimes it was a one-on-one encounter, I understand. Sometimes there might be a couple of them. How did the peer-to-peer impact your, you started using it for remediation. Was there any impact there from that?
Significant impact. So one of the first places that we incorporated it was in the health assessment course. And so these students, much like any nursing program, at the midterm, they have to do a performance exam on whatever systems they've learned so far. And we have a high benchmark at UMass. And so if the students don't meet that benchmark, then they have to come back into the lab. And our cohorts used to be smaller, right? Nursing programs are being challenged with all sorts of issues. We've got lower faculty, we've got higher turnover, our cohorts are growing in size. And so we needed to be really strategic about how we approached the remediation, because it wasn't an option just to water that process down. So we have 3 students come in at a time, and we put them in a group, and using the peer-to-peer application, and under the supervision of a graduate student or some of our sim educators, the students spend 1 hour. And in that 1 hour, they rotate through being the facilitator. So they are taking off the
List
right on their.
requires an active participation, right?
It does. So they're watching. The second student is the participant, the learner, who's actually doing the skill, right? So maybe they're practicing their cardiovascular assessment again. And the third student is the patient. And so what we do is we round robin, and in that 1 hour, the students are able to do the skill, assess somebody else doing the skill and give them an evaluation.
Wow.
And have that skill done on them. So we saw tremendous success with that. We went from like 60 retakes to 9 from
Wow.
one semester to the next.
Yep, that's significant. So during that remediation, it's not as if you have to have a faculty member tied to a student. But I know that there are faculty members present. How do the faculty, or do they more or less facilitate that session and allow the students to go unless there's a question problem? How does that free them up?
So it frees them up because we can have, our skills lab, much like others, we can get 30, 60 students in at a time. And so I've decreased the number of faculty. I might have a couple of grad students rotating through, checking in with the students, keeping them on task. That's something that, we have to do.
I'm sure everyone relates to this.
So what the students will do is, as they are going through the checklist, we do have hint text, because you have to remember, these are the same level learners. So how do you put 2 students at the same level who are learning the same content and ask them to now evaluate the other person's performance? Mm-hmm. That can be tricky, and there's some ways that we've addressed that.
It's a question that we've been challenged with the introduction of the peer-to-peer sim capture for skills that we have, that Laerdal has. It is, we've had the question. And so what we've done is we have impact managers who actually give this type, right? We learned that hint text was very valuable because I could give something from a textbook, for instance, that reinforces the point that I was trying to make. I could show a picture of what it wants to make. So our impact managers now are helping kind of spread this, because I think, when we speak peer-to-peer, I think sometimes, I know I always did, that was just me and my partner goofing off, right, with no supervision or something, and Chris, your students gave us a good
right. I think to speak to Rosemary's point about keeping the students kind of on task, I think that having this structure actually does, because they have a rubric in front of them. They know what specific steps they're to do, and it explains this is the criteria to say that the step was done correctly. So you're not just saying, now go practice your cardiac assessment. You're telling them exactly all the steps involved.
Mm-hmm. Yeah, I remember that feedback from one of your students. So those are the nice stories, right? You got a nice story going, but Rosemary, data is not always good, is it? Right? I know all of you know this. Data's not always good, and I know you've had some experience with that. Tell me a little bit about data that you've seen. Maybe one that looks like that. Looks good.
It does look good, doesn't it?
Looks real good.
So I don't think that there's any such thing as bad data. There might be data that tells you something you don't want to know, or that you wish you didn't see. But here is an example, and I know the viewers can't see this, but the take-home message here is that the green is an excellent rating.
Excellent.
So exemplary, right? This was from it was from a rubric that the clinical faculty were evaluating students using the Lassiter clinical judgment rubric. Mm-hmm. And I took a look at this and I saw this green. I thought, wow, this is really great. You know, our students are exemplary. And I looked at it again and I said, wow, this is really interesting because this is their first simulation that they've ever been through. And so what this told me was that
y'all are really good.
They're really good. I said they were good at UMass at the start of the program.
Well, I won't take that away from the students, but I saw that there was an opportunity for some faculty development here. Mm-hmm. And so we addressed it in between semesters, and I saw the same type of data come back after semester 2. So
even after discussing it and saying, this isn't it's not what we're looking for, right?
So you hit these, bumps in the road. And mm-hmm. So what we did is we changed the format of the questions that the faculty were going to answer to give the students feedback. So instead of using a 1 through 4 rating, we took all of the same categories and we just asked the faculty to free text some comments back to the students. And at the end of that semester, we then saw that the feedback that was being provided was much more valuable. The instructors were taking the time to read the evaluations and the reflections, and then, really guide the students through those four phases.
Mm-hmm. And Jenny, you also have a peer-to-peer experience. I know we've heard a couple of peer-to-peer experiences there. Tell us about your peer-to-peer. We've worked with you, I think, probably 4 semesters at least.
Yeah. We have kind of an upside down story with peer-to-peer. We did implement it about, I think, 3 semesters ago. Yeah. And the first semester, we implemented it like in the foundations mm-hmm. group. We have an online program and an on-campus program. So when we implemented peer-to-peer with SimCapture, we did it differently in both programs. The accelerated online tied it to an assignment, so it was a requirement in that mm-hmm. course. They had to do so many peer-to-peer evaluations. The campus group was more student-led, but high utilization that first semester.
Yeah, that's the graphic here is, I remember this being, we were pretty pleased with this. This is the on-campus only here, and there's 1,100 something skill. There were a huge number of skills attempts. You can see 782 nasogastric insertions. So that means the students were going. How'd it go from there?
Well, we thought we were blowing it out of the water. We thought we were.
I did too.
Doing great. So we've got all of these big usage numbers. Second semester, AO, the online program, kept their procedure the same. Mm-hmm. On campus did as well, but they saw their numbers drop off a little bit. Mm-hmm. And really no change in, other than student usage data, no change in outcomes. Mm-hmm. So third semester, AO, our online program, again, kept it the same, but our on-campus group didn't use it.
I'm really surprised at this because we looked at the number, we can see the number here. There was good utilization there.
But that's all we had. That's all we looked at. And so going back to Rosemary's point, talking about students, evaluating students, didn't quite feel like they were ready at that point. And that was on us. So we kind of looked at it now, what can we do to make the data good, make the data that comes out of it usable? Mm-hmm. And that's why I love working with this group, because we're about a semester behind. And I love it because now I can learn from what they've found. But what we're going to look at is we're going to look at the skills degradation across the program, how we can maybe integrate peer-to-peer in multiple courses to prevent that. We're going to look at different data than just student outcome or student usage data, competency, competence, things like that.
Mhm.
So we have a plan.
And tell me a little, that plan didn't just pop out, right? You asked the question. I remember we're stunned that the on-campus group didn't use it, and it really caused you to reflect. Tell me about that a little bit.
Well, again, we had to look at what we didn't do with the
Yeah.
data that we had and how we use that.
Yeah.
I'm a fan of the nursing process. So my people that are watching will attest to that. We looked at our assessment of our program. Now we're planning our interventions on how to implement those.
So you applied the nursing process,
Yeah.
you came up with a diagnosis,
Mhm.
you applied a plan, and then the next piece is the implementation, or correct, am I right? And then the last one is the evaluation. So good, yeah, so we look forward. I like that too, they recognized, as you just mentioned, about the degradation of the skills. And you guys know where I came from in my previous career when I worked with Laerdal and with RQI. I'm an advocate of the low dose, high frequency approach. It's not just cardiovascular resuscitation that this applies to, it's all the skills that we do. And so I would say collectively, this is something we've learned together about skills, is it really needs to be across the curriculum and not just here. Do you agree?
Agree.
Mhm.
Completely.
Yeah.
Good. So we have some polling questions. Again, let's go to just a couple of other polling questions. And the first one, so here first questions I was asking about was about your high fidelity simulation. So this question is about your skills, not high fidelity. And does your organization employ a deliberate peer-to-peer methodology, right? So again, think of the word deliberate there, is that you are actively implementing a methodology of utilizing peer-to-peer in your program, in your class, in your sim center, where they're deliberately scheduled events. Yes or no? And can we see the responses? So this is very few. And I think that this really goes with what we're learning. About 28% of our respondents actively do it. And the 72% of the respondents don't employ a deliberate peer-to-peer. Next question for me, please. Kind of the same question. Are you collecting and analyzing data on your summative? So Rosemary talked a little bit about she collected her data and evaluated her summative performance. Jenny mentioned you didn't collect the data on the summative, right? So I'm asking the viewers and listeners, are you collecting and analyzing data for your summative evals? Yes or no? And let's have that. Wow, about the same. Only 23% are collecting and analyzing data on summative skill performance. That's low. I expected that one to be real high, but that's a surprise. And 77, of course, saying no. I mentioned when I started this, we surveyed schools. We wanted to know, my partner Rich and we surveyed people, we spoke to them, we saw them in person, we did a number of things, and we found really that the vast majority of people are just using satisfaction surveys. And it was by far the most common evaluation that we saw. And so with that in mind, what I'm curious about is that's probably the case. I'm thinking the people that have joined this, we had a very good attendance, I think. They're interested in hearing, wow, you're talking about the Creighton, you're talking about this, you're talking about getting the data, changing data, 10 years of experience. Where do I start? And so Rosemary, I'd like to ask you, because Jenny just talked about the nursing process, and I know that you take this same approach. So what advice would you give to the listeners, viewers, where you would start?
I would say that it's important to remember that we've been doing this for a while. We didn't get to this point overnight. So first steps, I would recommend looking at what data are you already collecting, because it could be on pencil and paper, it could be electronic, but what is it that you're capturing already? And start there. The second thing I would do is I would challenge people to see what they're doing with their data. Are you making, is this meaningful for you to either implement change or drive your next action in your program?
Or is it in the file cabinet?
Or is it in the file cabinet? Start with something that is low-hanging fruit. And for us, we started there. We were doing the satisfaction and the confidence, and that's great. I'm very happy that the students like the experience, but we were more interested in, are they on the road to meeting the objectives so that we can successfully get them through this program so that they're ready for this transition into practice. So we moved away from satisfaction and we hit the dash tool with the student version.
So I have the graphic for the
okay.
nursing process,
All right.
because I know that this was employed for this. I wouldn't say we directly talked about doing the thing. So speak a little bit about that dash and how you implemented it into your program.
So for the dash, we started with the student version. It is through the Center for Medical Simulation. And it evaluates, the student evaluates the facilitators on how well they perceived the pre-brief, the simulation, and the debrief. It's really about evaluating the facilitators.
It's very objective, right? That's the great thing about the dash. It's an objective tool. And besides the student, well, we'll talk in a moment about it, but they do have the instructor too. But go ahead, I'm sorry.
That's okay. So so we started with the student version, and we then moved to the instructor version, where now the sim educators are able to view their debriefings and check off themselves and see. It's a nice way to figure out where you need to focus your attention on faculty development. One thing that I will say, not about the nursing process, but it's really important that we take into consideration all of the types of assessments and evaluations within any nursing program. This should not just be the teacher evaluates the student. We've talked today, students working together with each other, students evaluating their faculty doing self-evals. So it really can take on a life of its own, but to start, the dash is a great spot.
I think so too. And I think both Chris, you and Jenny have both experienced the dash. And so you're living the process, Jenny, right now. Again, you mentioned at the start about, new building, good chance to revisit our curriculum and things. Tell me a little bit about what you would say to our audience.
So to get started, again, I love the nursing process. So you have to do a deep assessment of your program, and that's what we did. We kind of uncovered a couple of needs. Faculty development or professional development was definitely one. The need for standardization was another. We have a very large faculty, and they are the facilitators for the simulation experiences. We also have a wonderful education team and education manager. Shout out to Stephanie Campbell and her
Stephanie
team.
Campbell, amazing.
That are leading that group. So that's my what do we call them? The dream team.
Team of champions.
Team of champions.
Yeah, I loved it. What did they come? Yeah, like what was can you give us a quick outcome of any of their work? How did they, assist you here?
Well, they are. We have several initiatives in place right now. One of the things that we're looking at is debriefing. We took a deep look at our debriefing processes, and they were not consistent across the program. So I don't know if I've said this already, but we went to a standardized, easy to use debriefing method plus Delta, but it can also be very dynamic. I know a lot of people think it's pretty simplistic, but it can also be very dynamic. So we, and I say we, they created some faculty development activities. This is a speed debriefing workshop.
Not dating. That's not
Kinda like
Chris.
the same, yeah.
Chris leaned forward here.
It's the same concept.
Same concept. It was wonderful.
Yeah, they spent, Stephanie and her team created some mini scenarios, and she gave each participant a card with a student presentation in debriefing, and sometimes they were troublesome. And so the instructors had to kind of ad lib and, answer to the debrief, conduct the debrief. It was great. It was very well received.
Yeah, I was just going to say, you just have to look at those faces. They're really enjoying themselves there and learning at the same time. How are you going to evaluate the effectiveness of your Plus Delta program?
I'm glad you're asking that. We have to get our house in line first. So we attended the DASH training through CMS for educators, Stephanie and myself. And we plan on rolling out, again, I love following behind these guys because I can see what they've done with the DASH. So that's our plan, to kind of ease it in to the faculty professional development in spring. We've already created some workshops live and online. So that's the debriefing process.
It is a team of champions.
It absolutely is.
You have a team of champions there really well.
Absolutely.
Chris, we talked about your Creighton data, and I know that having worked with you the time that I've worked with you, you are very deliberate in your approach to implementation, right? Some people, I'm not going to mention any names, but Rosemary will jump head, feet first, flips, somersaults, she's in it. You're very deliberate in your approach. And so I think, when we speak of the Creighton tool, a lot of people have heard of the Creighton tool. There is some use of the Creighton tool, certainly. Tell us about your experience there. Why Creighton? What would you say to people?
So I find it really valuable because it is objective. The tool was produced at Creighton University. If you were interested in using it, you do need to go to their website and request the permission, which they're very generous with granting, but they want you to go through the training to ensure that you're using it appropriately. So it is a 23 item scale, and it measures 4 key areas: assessment, safety, clinical judgment, and communication. And what we found in terms of the implementation is you have to be really thoughtful about how you're going to operationalize these items. So for example, you have an item where administers medication safely, but then you really need to think about, well, what does that mean in the context of the particular simulation that you're doing that you're going to use this Creighton for? So if you have multiple faculty that might be running or debriefing that simulation, you need to kind of have a shared mental model of what it is that you're looking for. So you need to make sure that you operationalize it. And this is where we've used hint text for ourselves and other colleagues that might be using the tool to evaluate a particular simulation.
I think that you need, as you said, the shared mental model, a consensus on what that is. I remember doing that with your people also, of all watching a simulation and then rating it, and then doing rated reliability. How far are we off, right? So I brought up a graphic showing the Creighton in its raw form, right?
Right.
No hint text, but you mentioned about adding hint text, and so tell me a little bit about how does this help you?
So if I'm the one facilitating the simulation, so I'm looking in this particular simulation, the students are expected to administer a dose of lorazepam to a patient experiencing alcohol withdrawal. So the things I'm looking for, did they calculate the dose accurately? Because they have to draw it up out of a vial. Did they actually measure it out correctly? Did they dilute it? Did they check compatibility with the existing IV fluids? Did they push it over the correct amount of time? So this is where, when we get to that more granular level, we found that they needed some reinforcement and the implementation of that particular skill.
I can see that objectivity. Rosemary, you're
I think it's important to mention here that these hint texts, you have to reach a consensus with the people who are going to be filling out this form. There is a lot of leeway, though, about the level of learner that this can be applied to. So this, I'm guessing that this is probably a junior, senior level student. For the student who is novice in that fundamentals course, these might be that they, check the name and ID band of the patient before they give a med. So there's a lot of leeway with the Creighton tool.
Yep.
I think it's important to have, we call it a skeleton, something to build on, like a template, and then add your hint text accordingly.
Yeah, it is. It can be used in multiple, and the training really reflects that. The training, we'll put some links in the chat for both the Creighton and the Dash tool, and we'll put one for SSH for some curricular development things also. Do we have time for questions? Yes, we have some time for questions. Okay, excellent. Well, I'm going to join the chat there. So if you have some questions right now that you'd like to send to us, we'll answer what we can. We only have a few minutes. I wish we could spend 2 hours. Honestly, I know that we covered a lot of things really quick, and there's a lot more that we could have done, but
It went really fast.
It went very fast, and it's always enjoyable with this specific group. So thank you so much for your insight and things. I'm going to jump over here to the
Yeah, while Darren's getting that pulled up, I would just recommend having colleagues like these to work with is so beneficial, because we all help each other, we all generate ideas and build off of each other's ideas. So, build your support community in terms of SIM evaluation.
And we've all implemented in different ways. So now we have 3 silos of ideas to share.
And we also know what works and what doesn't work.
Correct.
Which sometimes the what doesn't work is more helpful.
Exactly.
Yeah. We have, I'm just going to grab some random ones. There's a bunch. And so for those of you who we don't answer your question here live, we will get to these questions and get them back to you. I think we have all the emails. Brittany Tower, and I'll answer this first one. It's a softball to me. I have SIM capture. Was this loaded into SIM capture and personalized per scenario?
Yes.
Yeah, so you load the Creighton tool, we loaded the Creighton tool in, and then the hint text was developed and added to the
right,
to
so
the
you can actually
evaluation.
copy the tool itself. You can have a raw one and copy that into your specific scenario and course, and then go in and edit it with the specific hint text for that simulation.
We have one from Amy Klein. How do you share the data with students?
That would be a dashboard. I think that would be very beneficial, that students could see their progression, just like I talked about earlier, I think that would build their confidence. So that would be a great addition.
We are able to share it from the portfolio, but so we can share any of the pre-course and post-course things that you give. So they're giving pre-course and post-course evaluations also. But Rosemary, you kind of are interesting in your Creighton data in that you don't share that with the students. That is strictly used.
So our Creighton, it's currently being used for our simulations. So they're the formative simulations, and we are using those for internal purposes only at this point. We could share it with the students, but that to me takes away the safety of, this isn't graded.
Yeah, we're in the same place. I mean, we're using it really for curricular evaluation and programmatic evaluation, and like I said, identifying gaps and then trying to identify how we can improve our teaching to help our students be successful. Now, it is important to point out, in the course of the debriefing, any errors or omissions would be brought forward and addressed.
Certainly.
So the students are getting that feedback. They may not just be getting a chart like what we displayed here.
We do have a question about the platform. You've all mentioned about the skills being done on a phone or an iPad or a PC for that matter. It doesn't matter. That's SIM capture for skills, and that we all use. We all use SIM capture Enterprise, and it has a skills platform to it. Got one from Brittany Tower. Is the evaluator only evaluating one student at a time in a scenario?
No, ours are team scenarios, so it's the group that took care of that patient. So that's one of the reasons why it may not be the best idea to share this tool with the students, because they could easily say, well, that was Maria that did that, not me. So again, we look at it more for programmatic evaluation than for individual student evaluation, and it is formative.
Same. We're looking to see if the group of students across the cohort and then from course to course, are we finding that we're not meeting competence in particular areas so that we can address it, with the clinical faculty. This isn't something that just lives in simulation. This should be threaded and connected to your clinical faculty, to your didactic courses, if you're really looking to make it all cohesive.
Data definitely shows a trend and things. It says, how can I increase, this is from Alice, how can I increase faculty interest in Dash or Creighton?
All right, Alice, this is what you do.
This is how you do it, Alice.
Alice,
This is good though. This is about implementing curricular thing, and we're going to put a link to SSH. There's a webinar that was just done on curricular development, and it's really good. It talks about political influence when implementing, and I'll let Rosemary tell you her political influence.
All right, so what I recommend is finding one or two people who will kind of take this journey with you, and that they are willing to give it a whirl. And I can tell you that for our health assessment, we now have it at the level where it's the whole cohort. But when I first started, it was just with one lab instructor and 12 students. And we piloted it. And what that did is it gave us the ability to then talk to the other lab instructors at the end of the semester and say, look, this is the impact that it's had on these 12. Is this something that you want to bring it? And it creates a buzz. And once you see other students in other groups performing and achieving those benchmarks in a faster way, then it's a pretty
proof of concept.
Pretty easy buy-in.
I think like starting small and building on your wins.
Yes.
And also, I know, like, I have a strong team in my sim center. Our sim coordinator Crystal Hockenberry and our operations specialists Jeannie McCurdy and I are pretty skilled with using the platform. So we don't want the faculty to be stressed by the technology. Yep. So we can help them build their course out, get their students in, do those pieces. And it's really their more the curricular integration piece of it.
It's good to show them how your wins.
It meets the basic need, right? It's some comfort and security, right? Because I don't want to look bad trying to operate something I don't really know what I'm doing, right? So it really helps.
And the students are very comfortable with it now, because now they've done it for several semesters. So it may be new to a particular faculty, but they're inheriting students that have already done it.
So we're at the top of the hour. We really wish I could continue speaking. We so enjoy our time together, and we learn so much from one another. And I really want to thank you again, not only for your professionalism, your dedication, all those things, but for your friendship. Is that I think that we've really established a wonderful relationship over the years, and I think that the work that you're doing is reflective of that. And so thank you so much for coming today and being part of our webinar. So if you would like to get some more information about leveraging your data throughout your curriculum, visit laerdal.com//simcapture. And you can find out a lot about what they've been talking about. They're all using it. And so again, thank you so much for joining us. Thank you to our guests. And I look forward to our future together.